Everybody, welcome back to another video or podcast here at Whiteboard Medicine. Yes, that is right. We are going to be coming out with podcasts as well. So check that out if you're interested in podcasts. If you're watching the video thing, welcome to the YouTube version. Today we're going to be talking about septic shock, the basics behind septic shock. We'll come out with some advanced lectures too, but this is going to be kind of basics foundations. So we're going to first start with what septic shock is. We'll talk about the pathophysiology of septic shock, clinical presentation, diagnosis, management, additional considerations, prognosis, outcomes, and much more. For those of you new to the channel, shameless plug for our Patreon page. We're working on buffing up our Patreon community. There's both free membership and tiered membership. We post all the outlines and study guides to the lectures on there. We also do practice questions. We have kind of daily public health updates too. A lot of good stuff on there, so check it out. In addition to that, we do have a weekly newsletter called This Week in Public Health. You can sign up below as well. That's starting to get a lot of following, so we're really excited about that. So two things to check out. No further ado, quick 30-second break for the introduction. Don't go anywhere. We'll be right back. Hey everybody, and welcome to Whiteboard Medicine. We appreciate you checking out the video. Here at Whiteboard Medicine, our goal is to create medical education content for all types of interested learners. That includes videos, practice questions, study resources, and much more. We would love for you to join our community by subscribing, hit that bell button. We're also working to build a high-yield Patreon page. It's going to be full of practice questions, video outlines, notes, commercial-free content, and much more.
None of these videos are intended to be acted upon as medical advice. Please pause the video here and read this disclaimer in its entirety before...
All right, thanks for sticking around. So, septic shock. Well, if we start just by trying to define loosely what septic shock is a life-threatening, that's fair, subtype of sepsis that requires rapid recognition and treatment. It's characterized by circulatory, cellular, and metabolic abnormalities that can lead to really high mortality. So if we try to decipher this a little bit more, septic shock has two words in it. One is septic, the other is shock. Shock, at its most kind of basal definition, is systemic tissue hypoxia. And this is that your tissues, your organs, are hypoxic. They're not getting enough oxygen. And that leads to tissue damage and organ dysfunction and multi-organ failure. Okay, so that's shock just in general. Then we talk about septic. Well, we've talked about sepsis on this channel before, and we know sepsis is when you get an infection and it leads to a deranged immune response. And that deranged immune response, although it is intended to help you, actually can cause organ injury. So septic shock is where you have sepsis and it causes shock. And yes, it's life-threatening. Yes, it requires rapid recognition and treatment. And yes, it's characterized by circulatory, cellular, and metabolic abnormalities that can lead to a high mortality. So all of that is true. If we think about what exactly it is, well, there is a formal definition, okay? We kind of talked about the informal definition, which was sepsis and shock, right? So it's when sepsis causes shock. But the formal definition we get from this thing called Sepsis 3, and this is a large kind of formal governmental organization that was birthed by CMS, although it has a lot of buy-in from different specialties as well. So this is somewhat Americanized, but it is applicable in other countries too, and there's certainly kind of international involvement in the definition of all these things. But they essentially define it below. It's when you have sepsis and you're in shock requiring vasopressors to maintain a MAP goal of greater than 65 millimeters of mercury, and this is despite fluids, and you have a lactate greater than 2 millimoles per liter. So this is the kind of textbook organizational guideline definition of septic shock. So you need to have a MAP, a mean arterial pressure of less than 65 millimeters of mercury after fluid. So it can't be that they came in with a MAP of 60, but then you gave them a liter of fluid and their MAP normalized. This has to be a MAP of less than 65 after fluid resuscitation, okay? And you need to require vasopressors to maintain that MAP. So this can't be someone with, quote unquote, chronic hypotension or someone who is not requiring vasopressors. Their definition is MAP of less than 65, requiring vasopressors after fluid resuscitation. And then you have to have some sign of end organ damage, which is why they have this lactate greater than 2 millimoles per liter, because this is a sign of end organ damage, and we'll talk a lot more about that. Okay, so that's the formal definition of what septic shock is. Obviously, the preceding rule here is you also have to have sepsis. You have to have an infection somewhere. So it has to be an infection that is leading to host immune dysregulation that then is leading to hypotension, a MAP of less than 65 after fluid resuscitation, requiring a vasopressor with some end organ damage, that lactate greater than 2. Okay, if we go to more informal definitions, sepsis with shock is profound circulatory and metabolic dysfunction, right, that can lead to that tissue hypoxia, which can lead to hypotension and shock. The mortality of sepsis is really high. Here we quoted 40 to 50%. You'll see things ranging from 20 to 50%. So the mortality of septic shock is very, very high. The reason for that is we honestly don't have great treatments for septic shock itself. We certainly have treatments for sepsis, and we certainly have bundles and things we do to try to address septic shock, but a lot of the dysregulation, which we'll talk about in the pathophysiology, doesn't have this firm treatment that can reverse that immune dysregulation, right? We kind of support the body and treat the underlying cause of the septic shock. And as such, this mortality has remained really, really high over time. The pathophysiology of septic shock, well, as we mentioned, septic shock results from a dysregulated host response to infection. Let's just ponder that for a minute because this is really, really important. So you need to have an infection and you need to have a dysregulated host immune response. That's your body saying, okay, there's an infection. I got to go attack that infection with my immune system. But that immune system activation is dysregulated to a degree where that in and of itself starts injuring cells in the body. Because your immune system has mechanisms to kill bacteria and viruses and parasites and fungi and cancer cells and all sorts of stuff. But those can also injure your own cells. So if you have dysregulation of that host response, that can lead to injury and death of your own cells, which can lead to tissue injury. It can lead to, release of more metabolites that then can cause vasodilation and some of these other things that we'll talk about in a second. So when you have that dysregulated host response, something starts to happen. And we're going to do an advanced septic shock lecture on the pathophysiology to really dive into this. So definitely subscribe and keep an eye out. It'll be both on the YouTube channel, Patreon page, as well as the podcast. But what essentially happens is you start to get immune cells, and we're going to do a little drawing here. You start to get immune cells. Let's just say, we'll draw this here, that have these receptors on them. And there's a whole slew of different receptors. One of the main ones people talk about are TLRs, toll-like receptors. When you have bacteria or viruses or things that are in the body, the toll-like receptor can recognize those. It can activate. There's things like pathogen-associated molecular patterns, PAMPs. There's also a DAMPs. But that activation then leads to this massive release of cytokines. Cytokines are a whole bunch of different molecules that essentially get released throughout the body and augment the inflammatory and immune response. So once there's those cytokines released, it starts to attract different immune cells, but it also can modulate some of our blood vessels, and you start to get vasodilation. So if this is your blood vessel normally, it starts to dilate. Let's just do some symmetry here. It starts to dilate, okay? So this would be the normal size of the blood vessel, more narrow, and then you start to get this release of cytokines, and it causes vasodilation, okay? Vasodilation. That vasodilation can lead to a degree of hypotension because as those blood vessels dilate, you still have the same circulating blood volume in larger dilated blood vessels, and that can lead to decreased blood pressure, hypotension, that MAP less than 65 we talked about. But that's only one piece of the puzzle, because the other thing that these cytokines do, if we were to zoom in on one of the walls of the blood vessel is coated in endothelial cells. These are the cells that make up the blood vessel wall lining. They have nuclei, just like all cells. Well, we shouldn't say all cells, but most cells. But what can happen is these cytokines, when they attract the inflammatory response, as well as some of the receptors on the endothelial cells, causes some capillary leakage. So these endothelial cells start to create openings within the blood vessel wall that allows fluid and cells and molecules to leak out of the blood vessels into the interstitium. And that's increased capillary permeability or capillary leakage. So you get vasodilation, capillary leakage, hypotension. All that can lead to organ hypoperfusion. Your blood vessels aren't able to get enough blood to the organs to oxygenate them. And that leads to that more kind of pathophysiologic definition of shock, that is tissue hypoxia, or not enough oxygen to the tissues. That organ injury and that tissue hypoxia can lead to that classic lactic acidosis that we talk about, an elevated lactate that so often can come with septic shock, although not always, but most times. And this is a spiral because as you get more damage to the blood vessels, you get more release of inflammatory mediators, you get more of that vasodilation, capillary leak, and this is an incredibly complex process. There's microthrombi and kind of relative adrenal insufficiency and all sorts of stuff, which we're going to dive into in the more advanced videos on septic shock pathophysiology. But yeah, this general pathophysiology is this spiral that ultimately, at the end of the day, leads to multi-organ failure, multi-organ injury. Right, you can get sepsis-induced cardiomyopathy, which is injury to the heart. You can certainly get acute kidney injuries or AKIs. You can get acute liver injuries or ALI. You can get acute lung injury, another ALI. All of these things can result from septic shock once you start to get that tissue hypoxia. Okay? All right, what is the clinical presentation? Well, the classical clinical presentation is related to what is going on. All right, so the signs and symptoms, you have to have infection first. And signs of infection can be things like fever, also low temperature, hypothermia, things like altered mental status. You can certainly have any signs of infection, burning when you pee, blood in the urine, skin rashes, productive coughs, abdominal pain, vomiting, diarrhea, all of those things that suggest infection. And then you get some signs and symptoms from the end organ injury to the hypotension or all those pathophysiologic manifestations. And those signs and symptoms include legitimate hypotension. But before you get hypotension, you often get tachycardia because as your blood pressure drops, what do we know? We know that cardiac output equals heart rate times stroke volume. So as your blood pressure drops to try to maintain cardiac output, your heart rate goes up. So even before you're hypotensive, you're often tachycardic. Okay, and then once your body's unable to compensate, eventually you'll be both tachycardic and hypotensive, but tachycardia usually precedes the hypotension. Now, there is a lot of caveats to that. Someone's on a beta blocker, calcium channel blocker, some other AV nodal blocking agent, or they have other comorbidities that prevent them from mobilizing tachycardia. And then tachypnea. I always say that when someone is tachypnic without lung pathology, it's a really ominous sign because it could be suggestive of just overall metabolic demand. Oliguria or decreased urine output, all these kind of go hand in hand. These are all kind of signs of either compensated or decompensating shock. So signs of infection, as well as signs of blossoming hypotension, blossoming compensated, decompensated shock, all that good stuff. And when to expect it, we will talk about this triad of infection, hypotension, and elevated lactate. That's when it's kind of smacking you in the head, right? If you've waited until you have an infection and hypotension and an elevated lactate to say, hey, look, we got it, we got septic shock, you're way behind the 8 ball. So really try to identify it. We sometimes talk about these things, compensated shock, which sounds like an oxymoron, because how can you be in shock if you're compensated? All right, but for the definition of the term shock, we talked again, tissue hypoxia. And you can have a small amount of tissue hypoxia or impending tissue hypoxia while still normotensive. And this is that compensated shock. Because as we said, as your cardiac output is heart rate times stroke volume. And as you get hypotensive, you try to crank up your cardiac output to maintain tissue perfusion. And to maintain that tissue perfusion and to increase your cardiac output, your heart rate goes up. And as your heart rate goes up, you might still be maintaining organ perfusion at this point. And this is when shock is compensated. All right, maybe you just have a wide pulse pressure, low-grade tachycardia. Maybe you're a little tachypnic. Maybe you're a little confused, a little altered mental status. But at this point, you're still maintaining organ perfusion. Okay, but at some point, this compensatory mechanism is no longer adequate. And that's when you start to get the blossoming end organ injury. And this is when your shock is becoming decompensated. But the best time you can identify septic shock is when it's still compensated, before it's in florid, in your face, infection, hypotension, and lactate. Because if you resuscitate and treat aggressively, that initial kind of compensated shock, people might call it severe sepsis. This is another term on the spectrum of sepsis, right? You start with sepsis, which is just infection. Then you get severe sepsis, which is infection plus organ injury, but without hypotension. And then you have septic shock, which is what we're talking about today. And this severe sepsis category is kind of this compensated shock category. And intervening aggressively there can make a huge difference, because once you get to septic shock, we already talked about that the mortality is really quite high. All right, so if you get to that septic shock phase, you're a little behind the 8 ball, whereas if you can intervene when it's sepsis or severe sepsis and prevent it from progressing, that is when you can really make a big difference. All right, diagnosis. Again, we have the formal diagnosis that people talk about, which is require vasopressors to maintain MAP of greater than 65 despite fluids and a serum lactate of greater than 2 despite adequate fluid resuscitation. You certainly need a infection as well. So the 3 components for the formal diagnostic criteria are 1, suspect infection, 2, persistent hypotension. The persistent is important because it has to be after fluids, and the 3, elevated lactate. Now, this is per those sepsis 3 criteria. There's still kind of SEP 1 guidelines that we talk about too, and SEP 1 is just a lactate of greater than 4, independent of whether someone got fluid, or hypotension after fluid. So persistent hypotension defined as a MAP of less than 65 after IV fluids. So there's that formal criteria, and then there's kind of the informal, more pathophysiologic definition, which is those signs of tissue hypoxia plus infection. And this is probably the most important bedside definition in our humble opinion, this tissue hypoxia plus infection, because as we said, there's a lot of different relative scales of compensation that different people can do, whether you're young, old, comorbid, not comorbid, all that kind of stuff. So sometimes we feel if you wait until it's florid, by the book Septic Shock, it's pretty easy to identify then, and probably behind the 8 ball. So really look for signs of blossoming tissue hypoxia and infection. But for formal criteria, when you're talking about, what's the diagnosis of septic shock, and there's all the kind of criteria guidelines and stuff that you have to abide by to meet compliance standards. This is the formal definitions provided. Step 1, lactate greater than 4, or hypotension after fluid resuscitation. And then the newest SEPS 3, which is suspected infection plus persistent hypotension plus elevated lactate greater than 2. All right, initial management. This initial management is based on, again, this bundle that people talk about. People talk about the 3-hour bundle, the 6-hour bundle. There's a push to have a 1-hour bundle, although this would be incredibly hard to achieve and is not in full force after a lot of the organizations went and said that that seems like something that's not going to be very achievable. So we still have 3-hour bundles and 6-hour bundles. All this, though, is these kind of mandated compliance standards. So that's what some of this initial management written here is, which we'll go through. But there's also just some general management concepts that are probably more important to think about. So initial management, the first concept is fluids. As we mentioned, these patients get vasodilation, and these patients get increased capillary permeability. And they probably have been sick and not feeling good and not eating and drinking much. So most of these patients, not all, but most of them are hypovolemic. They're intravascularly depleted. And what the sepsis bundle criteria would suggest would be that they should get 30 cc's per kg of intravenous crystalloid. Now, this is probably going to fall out of favor, and probably has fallen out of favor in some places, but this is the standard for compliance that they use, and some patients certainly benefit from this. But other patients need kind of a more dynamic volume assessment. How to do that dynamic volume assessment is part of incredible wide-scale debate. Some people talk about ultrasound. Some people talk about fancier ultrasounds like VTIs and Vexus and all that kind of stuff. Some people talk about trending lactate. Some people talk about pulse pressure variation and straight leg raise and fluid responsiveness. And is it fluid tolerance, intolerance, and responsiveness? And is it a linear progression or more of a spectrum? All these are really advanced topics. Things we'll probably cover on the channel in the future. But the start of this is that most of these patients do require intravascular fluid. Compliance bundles would suggest you should give 30 cc's per kg, but we're a fan of more precision medicine with some dynamic assessments. All right, blood cultures. All these patients should get blood cultures. It's important to try to identify what organism is causing this infection, and then they should get IV broad spectrum antibiotics. The keys here are IV intravenous and then broad spectrum. And this doesn't have to be the most broad spectrum, but some degree of broad spectrum antibiotics. If they're hypotensive, we should use vasopressors. The first line vasopressor recommended is Norepinephrine, brand name Levafed. This is the first line vasopressor for many, many conditions, including septic shock. So if the MAP is less than 65, low threshold to start norepinephrine. And then you want to monitor things. We still trend lactates. There's certainly some debate there. Monitoring the MAP, monitoring urine output. So really monitoring signs of end organ dysfunction, okay, is the big thing here. So make sure the kidneys are working with good urine output, trend the creatinine, trend the liver function test to make sure they're not developing acute liver injury, trend the oxygenation, make sure they're not developing acute lung injury, watch the cardiac function, whether that's with bedside ultrasound or other modalities, trend the lactic acid. Don't put all your eggs in any one of those baskets and be reactionary, but all of them together can kind of paint a little picture about general organ perfusion. Additional consideration, source control can be very important. So you always want to make sure that there's source control. If someone has an abscess, it needs to be drained. If someone has an obstructing stone, obstructive nephrolithiasis with hydronephrosis, they need to have drainage of that, whether it's a ureteral stent or percutaneous nephrostomy tube. If someone has cholangitis, they need decompression of their biliary tree. If someone has necrotizing fasciitis, they need debridement of that infected fascial plane. Sorry about that. So source control is important. When patients are not getting better, sometimes it's because they have a source that has not been identified. So that's something to think about that you might have to come back to. Steroids, if shock is refractory, there is some debate, although I think most people would agree that stress dose steroids are indicated, although when to start those steroids, which steroids to choose, is it hydrocortisone or hydrocortisone plus fludrocortisone or something different? Lots of debate there, but if someone has persistent vasopressor dependent septic shock, most people would agree that steroids are probably indicated, but again, some debate in the literature. And then monitor glucose as you want good glycemic control, and then in addition to that, early nutrition can be important too, assuming perfusion markers are improving, that their vasopressor requirements are going down, maybe their lactate's going down, and consider early enteral nutrition. Prognosis and outcomes, unfortunately, and mortality, as we said, is somewhere between 20 and 50%. Early recognition and management does reduce the risk of mortality. How much is unclear, but we've hit a little bit of a plateau. We probably need some more aggressive research into other ways we can help treat these patients. But identifying early and treating aggressively early is absolutely critical in trying to blunt some of that downstream morbidity and mortality. We do have a little visual summary here. If you're listening to the podcast, we'll read some of it. If you're watching the video, we do have a little summary slide here. And that is septic shock definition. To review, sepsis with vasopressors needed to maintain a MAP of greater than 65 and a lactate of greater than 2 despite adequate fluid resuscitation with signs or suspicion of infection. So pathophysiology, infection leads to immune dysregulation, which leads to vasodilation, capillary permeability, hypotension, poor tissue perfusion, lactic acidosis, and end organ injury. Clinical presentation, we often see whatever is causing the infection, as well as altered mental status, tachypnea, tachycardia, fever, hypothermia, hypotension, elevated lactate. You certainly don't often have all of these things. You might have just a few of them, and that is much more typical. And management concepts are intravenous fluids, whether that's 30 cc's per kg, as some of the guidelines would suggest, or whether that's a more dynamic volume approach, some to be debated. Broad spectrum antibiotics early, get blood cultures, and support patients with vasopressors for MAPs of less than 65. Norepinephrine, we spelled it wrong. Clinical pearls, something that comes up sometimes I hear people say, which is kind of catchy and true, but time equals tissue. Like people say time equals brain with stroke and time equals myocardium. It's not necessarily different for sepsis, right? Now, some of those organs bounce back better than something like a brain or a heart does. Your kidneys and liver might bounce back a little better, but time does equal tissues. The longer those tissues and organs have hypoperfusion from septic shock, the more damage they're going to have, and the more kind of chronic damage they may have. So treat early, treat aggressively, and have a low clinical index of suspicion so that you diagnose this early enough. Clinical pearls here. Lactated ringers is often preferred over normal saline. This is highly debated. We personally often use lactated ringers, although there is evidence to suggest that it might not matter. There's evidence to suggest that lactated ringers are better, so highly debated. And then reassess frequently. This is really important. These patients are not resuscitate them once and forget about them. These are patients that need frequent reassessments to make sure you're doing everything you can to get source control, treat the underlying infection, and support the organs with vasopressors, fluids, and what have you. So not set and forget it, definitely dynamic reassessments. All right, that's all we have for septic shock basics. Let us know what thoughts, comments, questions you have down below. Hopefully that was helpful. If not, we apologize. Let us know how we can make it better next time. And if so, let us know in the comments. Either way, subscribe to the bell button. We'd love to have you. Check out that Patreon page. We'll put the study guide for this video on the Patreon page. And stay well, keep learning. We'll see you next time.